So what we're going to go back to is talking about the future. And we've got the three big categories of immune-based therapies that you all are aware of. As I mentioned, iberdomide and mezigdomide are the two new CELMoDs, which are cousins of the IMiDs. And then you saw from many of our speakers this morning the future of other bispecific antibodies targeting BCMA, or targeting GPRC5D, or potentially targeting FcRH5. So we have lots of new things that are coming down the pike that will make access and treatment for our patients even better. So when we think about reasons why immunotherapy is not successful, there are a number of potential reasons why that could be the case. And obviously, T-cell characteristics represent almost 50% of the mechanism of action. We know that a bispecific, its goal is to bring a T-cell in close proximity to a malignant myeloma cell, and then that subsequently can impact cell death. And so if you don't have good numbers of T-cells, if you don't have activated T-cells, if you have exhausted T-cells, or you have had such prior therapy or recent alkylator therapy that limits T-cell functionality, that will potentially limit, maybe not response rate, but certainly duration of response to patients with bispecific antibodies. At the same time, there can be other characteristics that impact T-cell function, and these include things like antigen expression, tumor load, high-risk genetics, biologically different disease, extramedullary disease, we know does represent a different target in myeloma. It's likely more difficult to get to. It's more microenvironment independent. Those cells intrinsically are more difficult to eliminate. And finally, the microenvironment itself, really focusing on a number of things that perhaps make it more challenging for the T cells to be functional, particularly things like immune suppressor cells or Tregs. Those can get in the way of an effective T cell synapse being created by a bispecific antibody, and those represent potential mechanisms of treatment failure overall. Now, I do want to bring up this idea that the IMiDs or CELMoDs really do, I think, in many ways, up the ante for what we're able to do in the management of immune-based therapies. So if we think about myeloma cells on the top, or we think about immune cells on the bottom, you can see that the impact of IMiDs really is dependent on the expression of the target. And in the myeloma cell, you see cereblon. When you bind cereblon with an IMiD, you ultimately result in a downregulation of Ikaros and Aiolos, which results in downregulation of IRF4 and MYC, and that ultimately causes myeloma cell death. But at the same time, you've got the same target. You've got cereblon, Ikaros, Aiolos, all those different pieces in a T cell. And when you bind cereblon in a T cell, you downregulate Ikaros and Aiolos. But in a T cell, that actually upregulates IL-2 and upregulates TNF as well. And the net result there is actually T cell activation. And so what that ultimately suggests is that these agents may be highly effective at helping us to augment the efficacy of our immune-based therapies, whether those immune-based therapies are antibodies, whether they are bispecifics, or whether they are CAR T cells. And so just to give you an example, the two new kids on the block, if you will, are iberdomide and mezigdomide, also formerly known as CC92480. Structurally, these have been developed in order to focus more on immune cell activation. That's why they're called CELMoDs and not IMiDs. And so they were engineered in a way to enhance the anti-tumor immunity effect on T cells and NK cells. And just as an example, you can see with iberdomide and dexamethasone in the phase 2 study that I led years ago, you see a response rate of about 30 to 35%. But more importantly, what you see here is activation of CD4 positive T cells. You see activation of CD8 positive T cells, and you have reversion from an exhausted phenotype back to an activated phenotype. And so the short way that I think about this is that iberdomide, in many ways, is like a cappuccino for T cells. It wakes them up. It makes them more effective. Again, a great partner for many immune-based therapies. Now, when you look at the effects of iberdomide in terms of adverse events, what you'll see are things like neutropenia, anemia, and leukopenia. These are much less common than what we saw with lenalidomide and pomalidomide. And more importantly, the grade 3, grade 4 non-heme adverse events are relatively uncommon, if not present, not at all. And so that, again, really represents differences in the engineering of these molecules that make them highly effective moving forward. Now, the other agent in this class, mezigdomide, also represents a step forward. It is even more potent than perhaps iberdomide. It does have a little bit more hematologic toxicity. And what you see in combination with either DARA or ELO is a very high overall response rate, again, suggesting that these are good partners. Many of these patients were DARA or were DARA resistant. And so this combination effect really is quite striking. So as you heard from many in the group already, BCMA failure is due to a number of different mechanisms. And so checking BCMA expression obviously is important, and you can do that by immunohistochemistry. But the reality is that BCMA may still be present as measured by IHC or flow, but there may be mutations in BCMA that make it more difficult ultimately to bind a BCMA-directed agent. And this was elucidated by Nizar Baylis and Palinieri up in Calgary, where they actually went through and looked at genomic changes in BCMA that are driven by constant pressure of the current dose and schedule of BCMA-directed bispecifics. And what they suggested was that it was that constant pressure that led to changes in mutations in BCMA itself that ultimately led to resistance to BCMA-directed therapies. What is interesting is that resistance to one may not be resistance to all of them, but the only way you're going to know that is by sequencing the BCMA receptor. So I think, as Dr. Krishnan suggested earlier on, getting that kind of information is going to ultimately be important as we make decisions about retreatment with a BCMA-directed therapy or moving to another target for many patients. Now, you heard from Dr. Giralt some of the complications associated with bispecifics. This is another one that I think we've talked about, which includes infection risk. And the reason this is important, as you can see, is that the risk of infections in the blue curve with GPRC5D is significantly lower than the orange or the green curves, which really represent BCMA-directed therapy. And particularly if you look at grade 3, much higher in the BCMA than in the GPRC5D. So those qualitative differences in infections are real. And a question I'm going to ask my panel is, what do they think about the dose reduction that's been recently put in the label for teclistamab and its impact on infections as well? So again, I think it's clear that BCMA-directed T-cell engagers are in fact highly active. You've seen about the other ones that are coming in development right now. Dose intensity that you need, I think, is ultimately an important question. Duration of therapy is an important question. You heard from Dr. Krishnan that the idea of cevostamab giving 2 years of therapy and then stopping, that's a really interesting and intriguing concept in a disease like myeloma, where we've typically hit continuous therapy as the main model. How to address infection risk, and I'm going to bring up the IVIG question that Dr. Giralt raised as well, because I think these are important questions for us as well. So the future, I think, is certainly very interesting and exciting, and I think we just got to figure out how to use these and or combine them to maximize the ultimate benefit for patients.